Okay, sorry, everyone. So thank you. We are about to transition to the next phase of our presentation, which is the multidisciplinary approach to health equity, Voices from the Field, Part 2. Again, we had started this conversation yesterday with conversations led by Whitney Rogers and Alison Jordan, and today we're welcomed by Christine Ivory, who will be from the Southern New Jersey Perinatal Cooperative, where she's the Prematurity Prevention Initiative project director. And then we'll also joined by Timothy Frie, who is the director of academic communications at Capella University. And so they're both will be presenting their ends. Christine will be talking about Black maternal child health, and Tim will be talking about promoting health equity with trauma-informed policymaking. We're having a slight change in the agenda, in which we're going to have Tim go first, and then it'll be followed by Christine. And so, Tim, the floor is yours. And I meant to ask before I started, did you want me to load your slides up for you, or do you want to lead it from your computer?
If you could load them up for me, that would be great. I'm using Canva for the first time, and I just want to make sure we don't have any issues. So
that makes sense.
Great. Thank you.
Did I stop sharing my screen? Yes, I did. Perfect. Because you don't want to see my desktop. It is ugly. Here we go. Load. Let me share my screen again now. Can everyone see this? Is it a good size on your screens?
It is.
All right. The floor is yours.
All right. Well, thank you so much, Maurice. And also thank you to Ebony and the entire CHPPD leadership team for having me. And thank you to everyone who joined us for the mid-year meeting. I'm really excited to
You're muted, Tim.
Oh, geez. So sorry about that. Rookie mistake. Such a rookie mistake. Okay. All right. Well, thank you so much to everyone who has joined us. And thank you, Maurice and Ebony, for having me. I'm really excited to talk with you all about how trauma-informed policy can promote health equity. And this is a topic that looks like is somewhat familiar for some of us here today, but it's a topic that's very personal for me. And it's something that intersects with virtually every single area of public health and all of our socio-political systems, but we don't really talk too much about it. So just to briefly kind of introduce myself again, I'm an educator, a consultant, and a Doctor of Public Health student, and I'm also the Director of Academic Communications for an education company. I'm also a certified trauma support specialist and have a professional certification in trauma and resiliency from Florida State University. And I truly stumbled into trauma-informed care and trauma-informed practice and the academic study of trauma. And it just really resonated so deeply with me on a personal level because of my own experiences. And it sort of filled the gaps about questions that I had in graduate school about why things were the way they were. And I've made a lot of big changes professionally to align myself with this work and be able to share this information with other public health, nutrition, and wellness professionals. So my goal in the short period of time that I have today is really just to introduce some of the fundamentals to you for those of you who aren't familiar, share a little bit of insight, and hopefully spark your curiosity or interest about how trauma-informed policy can impact the work that you're doing in your community and the organizations that you work with. I'll start by just kind of overviewing why this is important, and then I'm going to talk about 5 common misconceptions about trauma-informed policy, and then I'll be sharing some key takeaways and some resources with you all. So we can go to the next slide. So when we hear the word trauma, we tend to think about certain events like natural disasters or an unexpected death, abuse, neglect, or similar experiences. And we also tend to think about post-traumatic stress disorder. But trauma is really more about the experience and the outcome of that experience more than it is about the event itself. And trauma does not always lead to PTSD, but PTSD does always come from trauma. So important events that impact people don't necessarily have to be labeled as trauma for them to be significant either. Sometimes people experience distress or a crisis or an adverse event. But regardless of the label that we use, it's always about the outcome of the event. So since trauma is classified in so many different ways, for the purposes of this presentation today, I'm just generally using trauma to indicate any sort of event that leads to any form of just biophysical dysregulation. So why is this important? Well, trauma is incredibly prevalent right now. Some research has shown that virtually all of us experience at least one traumatic event in our lifetime, and more than half of these events occur during childhood. Also, virtually all of us are exposed to distressing events and are under chronic stress, which we just heard a lot about. And this constant exposure to chronic stress can be equally as dysregulating in the long term, just as a short-term or acute traumatic experience can be. And in fact, there's research that was published over the past year that examined the traumatic and distressing events of 2020, and those events have been correlated with declining mental health and a whole myriad of pathology in a number of different populations, especially children and teenagers, Black and brown folks, people of color, LGBT plus, and a lot of frontline workers, including healthcare workers. So if you work with humans at any sort of capacity, whether it's data or you have a community-facing role, you are more than likely working with people who have experienced some form of trauma. Trauma is also incredibly pervasive and ubiquitous in that it has just so many negative implications that reach across the entire micro, meso, and macro social landscape. And I'll be diving into this more in a little bit, but the effects of trauma extend far beyond the individual and their immediate social group. Additionally, trauma is so highly stigmatized. There's so many biases and stereotypes and stigmas associated with trauma victims, and even the terms trauma survivor or just the word victim hold a lot of stigma. And it's, these marginalized communities that frequently experience trauma. So we kind of have this compounding effect where there's, stigma compounding, or stacking rather, which really kind of amplifies the disparity here. Of course, these stereotypes and biases just kind of perpetuate all of the inequities that we're talking about frequently in the public health space. Next slide. So this is a snippet from a really good paper by Bowen and Murshid, and they developed this really simple framework for trauma-informed social policy. And here, I just wanted to throw this in for those of you who might want to take a look at the slides later, because they highlight that even though no one specific person is immune from trauma, certain types of trauma are more frequent in certain populations due to systemic inequities and structural injustice and dysfunction. So, very much in alignment with the theme for our meeting today, because this really highlights how a trauma-informed approach to policy can directly promote not only health equity, but also, other forms of equity like economic equity and justice equity and, education equity, all of these other forms of equity that really intersect with public health. Next slide. We can go to the next slide. Thank you. So if we really want to promote, equity across this entire social landscape and have the biggest impact on public health through our policy efforts, then we really need to make efforts to shift away from this kind of reactive approach to trauma. And, this approach that really focuses solely on the individual and their family, and start looking at this through a preventive and proactive public health perspective that is through this trauma-informed lens. Next slide. I'm about to dive into the misconceptions here in a minute, but I first just want to briefly summarize what trauma-informed care is for those of you who may not be as familiar. And in essence, trauma-informed care is really this framework of applying 6 different principles in practice. The principles of safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and acknowledging the importance of cultural, historical, social, and racial and gender issues. And when I see this illustration presented in other presentations, I often ask myself, like, okay, so how would a public health professional actually apply these principles? And that's a really important question because, theory and insight will only get us so far, right? So given the time that they have today to talk about this, I won't really be diving into those specifics, but as I mentioned earlier, I will be sharing some resources that will answer the question of, how do I apply this in practice, or what does it look like to be, fostering collaboration and mutuality in the setting where I work. Next slide. Okay, so let's go ahead and dive into some of the misconceptions. One really common misconception about trauma-informed policy is that it's about making policies for direct trauma support programs. And while trauma-informed policy does involve advocating for and laying the framework for programs and initiatives and different projects that specifically address trauma, that's not necessarily the case. Next slide. One example where trauma-informed policy and advocacy has led to legislation for something that is trauma-specific would be this House Resolution 8544, which is a resolution that was introduced during our last Congress and unfortunately did not make it through committee, but I believe it is being reintroduced by Representative Ayanna Pressley. And this legislation basically called for the United States government to provide grants to local health departments to assess and implement different measures for addressing trauma in specific communities and addressing the downstream consequences of adverse childhood experiences, or ACEs, in certain communities. However, trauma-informed policy, again, it's this lens through which we can view all policies, not just policies about trauma or mental health, because trauma can come from so many different upstream sources. So it's not just about providing these direct trauma programs or trauma treatment, but more so providing an entire approach to all policies, kind of like, the health in all policies perspective that some of you may be familiar with. So, this resolution doesn't really look at the upstream consequences, or the upstream causes of trauma. What leads to traumatic events? What leads to ACEs? And we certainly can't legislate away trauma. That would be great if we could do that. We certainly can't write policies that just, eliminate all the traumatic events. But what we can do is advocate for legislation that is proactive and preventive of trauma, things that lead to that trauma. So the key takeaway here is that, the trauma-informed approach to policy is an approach to developing inclusive and equitable policies across the board based on these principles, not just creating policies for trauma-specific programs. Next slide. Another misconception is that trauma-informed policy is about legislation and funding allocations for human resources. Now, as I just mentioned, that's part of it, but true trauma-informed policymaking is far more intersectional and less myopic, right? So we can view our organizational systems and policies through this lens. We can view the dynamics between our community and our frontline and community-facing public health staff through this lens. And we can view our advocacy efforts through this lens. So the takeaway here is that trauma-informed policy involves viewing interpersonal, organizational, social, psychological, and political dynamics through this trauma-informed lens. Next slide. Another really big misconception about trauma and policy is that trauma and social work are exclusively mental health and social work problems. And for this reason, it just doesn't fall within the realm of public health. And, for some of you listening, this might kind of seem like a no-brainer, given that we're talking about this today. But many folks still don't really view trauma as being integrated or interconnected or having an influence on health status as a whole, or they simply aren't familiar with some of the wide sweeping implications of trauma. And I'm sure many of us here who have public health or allied health backgrounds and not just mental health backgrounds could attest to the fact that these topics aren't really covered in detail in public health education or training programs. Next slide. This is just a snippet from the introduction of a really fascinating mixed method study that was published in late 2019 that summarized this very comprehensive interdisciplinary engagement to build a trauma-informed and resilient community in Pottstown, Pennsylvania. And the researchers here just really did a fantastic job at illustrating how becoming trauma-informed not only involves mental health and social services access and delivery of those services, but also how public health, the education system, public administration, the justice system, and virtually all levels of government and social systems play a role in community resiliency and community trauma. So the key takeaway here is that since trauma is just so pervasive and so ubiquitous and has wide sweeping implications, approaching it from an integrative public health perspective can lead to far greater outcomes as opposed to just trying to address the singular outcome of trauma within an individual in a silo. Next slide. The fourth misconception is that trauma-informed policy focuses mainly on people utilizing mental health and social services. And based on what I've discussed so far, you probably already know that this is, certainly not the case at all. Next slide. I think a really good, illustration of how trauma-informed practice, policy, and care can stem from other sectors of public service is the Missouri model, which was and remains this large multimodal initiative in the state of Missouri that involved basically applying different restorative and reparative justice practices within their criminal justice system. And whether it was explicitly spelled out or not, the principles of trauma-informed policy and care were really hallmarks of this initiative. And the outcomes set a really strong precedent for a lot of reform and inspiration for other programs in other regions. And I think this also really highlights how other systems may not only contribute to trauma or be a vector for trauma, but also how other systems, even outside of public health, can really contribute to community recovering and healing from trauma. Next slide. So here the key takeaway is that many of the same people who experience trauma also utilize and are impacted by other public services beyond just public health and social services. The last misconception that I'm going to share today is this misconception that talking about trauma or disclosing trauma is required to be trauma-informed. And that's not really the case at all. Trauma-informed policy and practice isn't really about asking people to disclose trauma or just talk about their experiences. In fact, doing so can be re-traumatizing and in many contexts and settings just wildly inappropriate and unethical. So instead, trauma-informed policy is really about fostering an environment that is supportive of those who have experienced trauma and is proactively mitigating the potential to cause trauma. Next slide. A really simple example of this is this organizational policy about trauma-informed leadership that comes from the Oregon Department of Health and Human Services. And, I just got to call out here that the state of Oregon and the Department of Human Services has really pioneered, in my opinion, the internal infrastructure of what it means to create a trauma-informed department and organization within public health delivery systems. This organizational policy set some baseline expectations for leadership and building resiliency within the workforce and within the community. Now, if anyone here watching today may work for the Oregon Department of Health or the Human Services, and you're thinking, wow, I've actually never seen this, or well, I certainly have a different opinion about this. I think you'll appreciate what I'm about to share as we kind of wrap up here in regards to the journey of what it means to become trauma-informed. Next slide. But the takeaway here is that disclosing trauma is absolutely unnecessary to provide trauma-informed care, and it's also not a key component of trauma-informed policy. So, as I mentioned, becoming trauma-informed isn't really just about creating documents or checklists. It's really about figuring out. Or I'm sorry, it's not really about what just happens between a community member and a staff member, but really what happens within an organization as a whole. And this journey to becoming trauma informed really involves 4 phases: becoming trauma aware, trauma sensitive, trauma responsive, and then trauma informed. But most organizations tend to kind of bounce back and forth between phases 1 and 3, while still using that label of being trauma informed. So we can go to the next slide. I'm super short on time here, so I'm just going to kind of quickly go through this. So a few key takeaways, and I just want to highlight here, some of this, since it is so intersectional and so many things are involved, there's a lot of things that we can do. One is, to incorporate these principles into our current and revised policy statements. Something that would go a really long way would be expanding public health education to include this information. You can talk about, exploring different opportunities to improve public health services within your department, and really just consider how trauma-informed practices can improve your current programs and potentially population health outcomes. Next slide. And here I just want to leave you with a few different resources. Feel free to reach out to me, or I'm sure if you reach out to Maurice or anyone else, we'll be able to get you connected. But Trauma Informed Oregon has a ton of really great resources for training and education. Another really strong resource is the Campaign for Trauma Informed Policy and Practice. They're a really impressive advocacy organization that is doing amazing work. ACES Connection is another really great one. And the National Conference for State Legislatures also has a lot of reports and resources for advocacy, policy, and programming that I'm sure would be helpful for many of you. So I think we can go to the next slide. Yep, these are just my references here. So thank you so much for everyone for listening. And I hope that some of this was insightful and sparked some curiosity or some thought for you.
Thank you for that wonderful presentation, Tim. I have to be honest, I didn't know what trauma-informed policy was starting, and I feel more informed and educated today. So thank you for expanding my lexicon, if anything.
Absolutely.
Is there any questions from the audience before we go ahead and I know we're interested in time, but I do want to provide a platform if folks have any questions. Catherine asks, can you give a specific example of how the approach was successful in the post-town or Missouri?
Yeah, so I would recommend, just request the slides, and I did include both links in my references where you can go to that study. There are several different renditions of the outcomes of the Missouri model that are freely available online that you can download. I know some private foundations have created their own summaries of the data as well. And I would recommend just starting there because the implications are very wide sweeping and many of these are still ongoing. So there's a lot of data to look at.
Thank you. Thanks so much. If there are no other questions, I am going to open the floor up for Christine to jump in and take lead. And I think we'll be catching up on time. And if Tim, for folks, we'll be sure to share the slides again and contact information because Tim will have to jump off momentarily. But feel free to send, if you have any follow-up questions, I'll be sure to relay them to him if they do come up in the chat after. Thank you. And Christine, the floor is yours.
Sure thing. Thank you so much. I'm going to work on sharing my screen. All right, can everyone see this?
Yes, you just have to make it, you have to enlarge it for us. There it is.
All right.
Thank you.
So good afternoon, or maybe good morning for those who may be on a different coast. I'm on the East Coast. I am so excited to be here today to talk about some really critical points around Black maternal and child health. I want to say thank you to CHPPD for allowing me to speak on these points. Thank you all for being here today as we discuss them. And not only will we discuss and dig into those points about Black maternal and child health, but of course, we're going to talk about some strategies as well as what we can do as public health professional, as community members, all these different types of levels. So my name is Christine Ivory, and I'm actually going to share my video. I realize I'm not. All right. My name is Christine Ivory. I am a project director for the Prematurity Prevention Initiative. This program is under the Southern New Jersey Perinatal Cooperative, which is a subsidiary underneath Family Health Initiatives in which I work. And so with our program at PPI, our main focus is in the name to prevent prematurity. We know throughout the whole United States, as well as in New Jersey, there is a crisis of babies being born too early, and we'll dig into that a little bit as we go. So the name of this presentation is, once again, Understanding Black Maternal Child Health and Equitable Strategies to Improve Health Outcomes. All right. For our agenda today, I'll be with you briefly, but for today, we're first going to talk about some learning objectives. Next, we're going to jump into maternal and child health landscape. So we'll talk about the landscape and statistics of what it looks like throughout the whole nation. Then we'll also narrow it down a bit and then talk about racial disparities in maternal and child health. And then lastly, we'll talk about actions that you can take as a public health professional and things that you can do within your community and your region. All right, so as far as learning objectives, once again, we are going to go into depth about maternal and child health in the next 10 to 15 minutes, just going over the landscape of what it looks like at a national level. So we'll learn more about that, have a more in-depth lens to see what that is looking like within our nation. We'll identify the impact of racial disparities on maternal and child health. We'll see those differences, and we'll talk further about that. And then lastly, we're going to learn those resources and have some actionable steps to walk away with for some sustainable change. All right, so first we're going to jump into maternal and child health. So we know that this is a very wide scope, so we are going to just go in and look at some of the statistics around what is going on right now in the state of our nation as it relates to maternal and child health. So what I did is I broke this section up into two columns just so we could have appreciation for looking at one to the other. So starting off on our left-hand side of the national aspect of maternal health, one of our big points, and I'm sure many of you have heard this here on the call today, that the US rates among the highest in maternal deaths compared to any developed countries. So that is a big stat, thinking about all of the different developed countries throughout the whole world and how US is at the bottom of that list as it relates to maternal deaths, or at the top of that list rather. Another fact is that 60% of pregnancy-related deaths are preventable. And so once again, we're thinking about the United States, we're thinking about this whole nation and how we have so much money poured into our nation, but yet our pregnancy-related deaths are up so high. Lastly, on the maternal side, we're looking at maternal mortality. And so we know that that has accounted for about 17 deaths out of every 100,000 babies that are born. And this is a stat that comes from 2017. As we're looking at the opposite side on our right-hand side, another sad fact, but 3 babies die about every 60 minutes. And that is a crazy statistic as we're thinking about our babies, our livelihood. That really tells a lot about your country, about how the life and the lifespan of your babies are. And then next we have about 1 in 10 infants are born preterm. And just to back up a little bit, a baby that is born preterm or premature, that's a baby that's under 37 weeks of gestation. And then lastly, more about prematurity, but a baby that's born premature, low birth weight, they suffer from a lot of different related complications and can account for infant mortality or infant death. And we know that that is a large cause, and we'll be talking about that further today. All right, so on our next slide, we're going to shift over to racial disparities within maternal and child health. Before we even get into all the details and the information behind this slide, I think it's really important to note the historical impacts of racial disparities as we go back and we think about slavery days and how James Merriam Sims has been really awarded as this name of the modern father of gynecology. And in fact, he in slave days had taken women to do experimental procedures on them, to do surgeries, and did this all without pain medicine, and of course without their consent. So when we think about practices like that, when we know that it has been all the way back in slavery days where people of color don't feel pain, and that same mindset is carried up until now, we know that there are some great impacts as we think about Tuskegee, as we think about the Mississippi epidectomies, all these different injustices that have been done to people of color. And I know it's not a presentation on historical concepts today, but I just want to really get that clarity out there of all these different injustices that have been made. And so before we dig into some of the numbers, I just want to go over some quick definitions of why we're here today. We're talking about health disparities. We're talking about equity. I know that you all probably know these definitions, and I just like to kind of bring them back to the front fold myself. But thinking about health disparities, we know that there are preventable differences that are experienced by socially disadvantaged populations. We know that those could be people of different races, different religions, different beliefs and backgrounds that face things such as poverty, that face access and lack of nutrition, and so on and so forth. We know that list goes on and on. And then as we think on the health equity side of why we're here today, we're thinking about how everyone has a fair opportunity to be as healthy as possible. Really as simple as that. And so the only way that we can get to the health equity side is if we break down those barriers from that health disparity side and try to disengage those different disparities and obstacles that are in that way. And so with this next video here, we're just going to take about 2 minutes, a little bit less than 3, to talk about a mom whose story really resonates throughout this whole nation and beyond. We're going to hear a story from Kara Johnson, who experienced a tragic loss and definitely some complications throughout her pregnancy. I'm not going to say too much. I'm going to let the video play, and then we can come back. So pause for me just 1 second. I'm going to stop sharing and I'll reshare. Or I should have stayed shared. Uh-oh. Okay. Everyone bear with me. All right.
When Kira and Charles Johnson first met in 2004, they planned to spend forever together.
Kira challenged me to be a better person in every single aspect of my life.
They were overjoyed when they welcomed their first son, Charles.
He's so handsome.
Their second son, Langston, soon followed, delivered through a routine C-section after a healthy pregnancy. It was April 12th, 2016.
Hey, Langston.
Their celebration quickly turned to concern, though, when Charles noticed blood in Kira's catheter. He alerted doctors, but says minutes turned into hours.
I'm begging, I'm pleading for them to do something.
Finally, he says, after 10 hours, doctors decided Kira needed surgery, but it was too late. Kira hemorrhaged to death. She was 39 years old.
Never imagined that I'd be sitting here today and that we would have left that hospital without my wife.
About 700 women die each year in the U.S. due to pregnancy or delivery complications, and African-American mothers are 4 times more likely to be victims than white women. Dr. Valerie Montgomery Rice says the causes of racial disparity aren't fully known.
I definitely think that there is a level of unconscious and conscious bias that occurs in medical settings.
Charles Johnson has turned his tragedy into action, helping to pass the Preventing Maternal Deaths Act, which became law last year. It requires states to review every pregnancy-related death. Charles' other fight, making sure his boys remember their mother.
The toughest question my sons have ever asked me is Mommy mad at me? Well, why won't she come home?
His answer, Mommy is in heaven and loves you forever.
All right, so I'm headed back to the presentation now. Let's see if I can get there. Oh, I apologize, everyone. But as we're reflecting on that video, I could see that video as many times. I've probably seen it about 50 times, and it really still hits me the same, honestly, that we are seeing these disparities. We're seeing a woman that was in the hospital where she announced that something was wrong, where her husband announced that something was wrong, and she sat there for 10 hours, was not prioritized, was put at the bottom of the list, and unfortunately died because of it. We're seeing systemic racism. We're seeing that people's voices are not heard, people of color specifically and historically. And this is just one example of the many stories that we hear every day. So I'm going to move ahead here. So for the impact of racial disparities, just digging into it a little bit deeper, for the United States, we see that Black mothers are 3 to 4 times more likely to have a preterm birth baby. We know that once again, that prematurity links right in with infant mortality, a baby dying before his or her first birthday. Next, that Black infants are more likely to be born low birth weight. Once again, thinking back to prematurity, a baby will be born at a lower weight. They might face different complications throughout their lifespan if they're born as a low birth weight baby, or if they're born early. Might be born with birth defects, or just have different types of complications because their system did not develop fully. Black women are more likely to lose a baby through stillbirth. We know that Hispanic mothers and birthing people that are of color are more likely to experience infant mortality. Once again, that is a baby dying before his or her first birthday. And then last, just a reminder from earlier, we talked about this, but pregnancy-related deaths are 60% preventable. So when we think about all of this, kind of combining in our mind and kind of digesting all this information, we still wonder as to why the 60% preventable death is even a statistic. As we look at more numbers here on our next slide, this is a graph here from the CDC, and it shows pregnancy-related deaths from all the way back from 1987 going up to 2016. And what we see is that trend on an upward swing, whereas in 1987, with every 100,000 births, we know that there was about 7 moms that were unfortunately passing away. As we look all the way up to 2016, we see that number has more than doubled and increased. But what's more shocking and what's more alarming is if we look on the right-hand side of our screen, where we look at the racial disparities and pregnancy-related mortality rates, we see that Black women or women of color are at a disproportionate, are affected at a disproportionately higher rate of pregnancy-related death and mortality compared to their white counterparts. We see that it is an extremely high number compared to other populations. And we know that that's very problematic. And I just want to note before moving from this slide, and something that we could all see, but this has been going on for more than 6 decades. And so looking at our next slide here of the causes of pregnancy-related death, a lot of times folks' questions are why? Why is this occurring? So when we think about it from a clinical standpoint, there are many reasons as to why moms are dying early from pregnancy-related death. One of the main causes that we see continuously is cardiovascular conditions, such as cardiomyopathy, such as different relations of the heart and blood pressure disorders, such as eclampsia, preeclampsia, and that list does go on. But once again, we know that a main cause of pregnancy-related death is simply because moms aren't being listened to, they're being silenced, they're being unheard. And we know that that goes back to systemic racism as well. So speaking about babies and shifting from mom for a moment, we have some rates of infant mortality throughout the nation. So you can look at this map here. It shows different rates, and you can see where your state lies. I'm on the New Jersey, Philadelphia side and over on the East Coast, but you can kind of look and kind of compare and see the rates of infant mortality. This goes from 2017. As we break down infant mortality and we look at race versus race and ethnicity and kind of funnel it down a bit, we see once again that there are disparities for women that are, or excuse me, babies that are Black and brown, have higher rates of death than those of their white counterparts. And we continuously see this theme. We see a gap that does not seem to be closing anytime. Okay, so transitioning down to our last points, we're going to discuss a few actions that you can take as a community person, that you can take as a public health professional. So first is education. Education is such a big piece to, oops, lost the point, to let people know about the crisis of Black maternal and child health, to educate your community and colleagues. I know that someone asked me at another panel discussion, they said, well, what can I do? And I said that there is, you know, social media. We are in this age, we're in this time that we can share this information and people want to know a lot about it. So definitely just taking a moment to share this with your networks is a big role to start out with. Another is promoting implicit bias training in health systems. So if you are someone that is working within a health system or just any type of working space at all, implicit bias is extremely important. So thinking about social service, thinking about hospitals and healthcare, we know that once again that women of color are a lot of times unheard, that they are a lot of times silenced. And sometimes we have that implicit bias. I mean, everyone has it, but it's good to be aware of your biases. It's great to have them in check. And a mandated implicit bias where it's just not a one-time training, where it's something that's continuously reminded of staff, is extremely important for progress. So another one is promoting preconception and early care. So we didn't dig into this too much today, but thinking about birth outcomes. If we have a healthier birth, or excuse me, if we have healthier care at the beginning of mom's prenatal experiences, such as before mom even gets pregnant, this is when we could have healthier birth outcomes. So it's really, really important to promote preconception care before mom gets pregnant, or early prenatal care if you're in the maternal health space or in a hospital health system. Also, developing maternal and child health practice guidelines and protocol. So once again, if you're in this maternal child health space, or if you're working pretty close to it, this is a great time to reevaluate guidelines and protocol for quality improvement, to see if there's some type of policy or some type of procedure that could be developed within practice or in a hospital system. We also want to share community services and resources with patients, with our communities, with everyone. And so on my next slide, I'll share some resources that you can share and that you can look into as well. Also, another one is collaborating with local organizations with aligned goals. So thinking about other organizations, and it might not be someone that's in the maternal health space, it might be a non-traditional partner. For example, our organization, we have partnered up with the NAACP, and we actually have made a lot of efforts, a lot of deliverables. We made toolkits, we made surveys to advance forward and get the voices of moms and to make sustainable changes. So just collaborating with organizations that are interested in this crisis. Another way to take an action or take a step forward is advocating for maternal health services. So we know that with the use of doulas, for example, that there are more positive birth outcomes for moms. I know in New Jersey, I can speak specifically, there are certain counties where if mom has a certain type of insurance that she could have a doula for free. I'm not too sure the whole state of the nation, but I know that access to doula care is extremely important. Positive birth outcomes are seen with doulas, and that's just one example. But as far as breastfeeding and lactation support, having access to midwives, just different birthing options for mom, just will improve outcomes and experiences overall. And then last, another easy one I would say is social media. We have so much that we can do on the social media side just by sharing simply a hashtag or a maternal health post. So you'll see on my next slide some examples of how you can share some of those resources. All right, so as far as some resources to share, I put a few pages that you can go to find more information. So I know that we saw a video earlier for Kira for moms that told Kira's story, and her husband is a big advocate and supporter of Black maternal health and improving outcomes. And he has written and definitely made his mark in the realm of policy. So if you're interested in being an advocate, I would say for Kira for Moms is really excellent source. In the background here, we have a picture of Kimberly Sills-Allers. She made an app called the Earth app. And what it is collecting moms' experiences. She's trying to see if even if the experience was good, even if it was positive, if it was negative, experiences that she just puts together so that she can bring for different policy change. And that's just one example of some really great things that are happening across the nation. And some wonderful names are on this list as well. So some take-home points. We know that Black infant and maternal mortality, we know it is a state of crisis. We know that there has to be some sustainable changes. There has to be people at the table that are ready to talk and ready to make some moves on some changes as we discussed. Health and racial disparities impact maternal and child outcomes. And we've seen that today as we were thinking through how racial disparities are so different among different populations. We know that Black women are 3 to 4 times more likely to die from pregnancy-related deaths than their white counterparts, and that also Black infants are nearly twice as likely to be born preterm than white infants, which is a really direct determination a lot of times for infant mortality. So last slide here, we all have a role in improving Black maternal and infant health outcomes. Really simple statement, but very true. We all have something that we could do to contribute back to improving health outcomes for women of color and people of color in the maternal health space. So I want to say thank you for your time and listening in.
Thank you, Christine. That was just an impactful presentation. It always staggering to see the statistics and the life stories that are out there. Any questions from the audience? And Alison, Alison, if you can queue up the link, I'll show the QR code in a few so that we can do a post following these presentations.
Sure. I have the post up for Tim's, and then I just switched it to the one now, so I can put up Tim's first again, and then switch in a minute. Hold on.
Yeah, I'm gonna pull up the tab real quick. So
I'm just gonna go.
Christine, there's a question in the chat. I'm not sure if you could read it. It's frustrating that many public and private health systems aren't yet comfortable with explicit anti-racism trainings and acknowledging the systems are racist. Implicit bias trainings are such a good start. Are you or other folks seeing change in this past year?
Absolutely, absolutely. I do understand the frustrations, and I'm speaking really narrow, very narrow from the New Jersey side. I know that our First Lady is very, very passionate about Black maternal health and seeing improvements in outcomes. So what is happening in our state is that we are moving to make more policies around mandatory implicit bias trainings throughout the state for all health hospitals and health systems. So we are seeing that change and that whirlwind start to happen. I would also say within our program, we actually made over this pandemic, we made a curriculum. It's called Power of Our Voices. And so it has a lot of themes, a lot of ties to implicit bias. And we're seeing so many people from all different walks really being interested in that training, wanting to know more about implicit bias. And it's really taken off. So we're really seeing a lot of improvements in people that want to know more and are interested in it. Thank you for that question.
Can you all see my screen right now? I'm sorry, Alison, I kicked you off so I can show the
Yep.
QR code real quick. And then for those who want to use the browser, again, it's e2polls.com, passcode CHPPD 2021. I'm going to stop sharing and open it up back to you, Alison. And while we're waiting, Christine, I did have so from a policy perspective, are there any key policies or agendas that, or agendas that the current administration can start putting forward that you think will be most impactful at this juncture?
Yeah, I think starting off with implicit bias once again, and not to beat a dead horse, I think that's really a great way to start. I was looking at a study, it was done maybe about 4 years ago, and it asked people in health service and those that are actually being trained to be physicians, if Black people could feel pain, if they do feel the same pain as other ethnicities, and their answer was no, they don't feel pain, and that was like about 70% if I'm not mistaken. And so it's things like that and mindsets like that that need to really honestly, frankly, be changed. So that's one. Another is I'm thinking about complications that happen during pregnancy and after pregnancy, such as preeclampsia, which is a really hot topic. So if we could find more ways to advance that forward, I know that California has done a really great job with their policy around that and really made some mandates around toolkits that they've been giving out to different hospitals and health systems and have seen an improvement over the last 10 years. So if we could do that from like a national standpoint, things like that really make a big difference.
And I'm going to just share the link, Black Maternal Health Caucus, underwood.house.gov, the Momnibus, yes. I've heard about that in the news recently. Good point. Thanks for sharing that link. And actually, that's a good reminder. I want to save this chat. So last time I closed out without saving the chat, and I was like, there was so much good content in there. So thank you. And thank you all. So we're seeing some responses here to the E2 polls as well, and we'll be sure to collect those and share with folks as well.
We'll have 3 people, people typing. And then we have the one from Tim.
Yep. Solid. So, and while we're waiting responses, so like yesterday, I'm going to do a slight change from what was in the agenda, and it's not really too much. We did plan on doing membership engagement activity, which is going to be another speed networking part 2 or part 3. But I wanted to go ahead and close out the meeting, and then for those who want to remain, we can stay on the line, and those can drop off, and then we can execute the session after. And I'll stop the recording so that that part of the meeting is just not recorded. So with that, let me go ahead and share my screen again. So again, I just wanted to thank everyone for their attendance and participation in today's call. And again, thank you to our presenters, Sarah, Christine, and Tim, all insightful and I thought very thoughtful presentations showing the breadth of concepts that are in the public health field. I did enjoy, really thinking about, it was, like I said, I think somebody made a comment, it was very enlightening to really see that it's not just me in the public health space of feeling, sometimes a little bit overwhelmed. And so it was good to have that exercise. And again, I learned the concept of trauma-informed policy. And so that was an interesting take. And then thank you again, Christine, for really providing some insight and more information on I would say, honestly, it's an epidemic in this nation that we need to address. And so I believe Ebony's still on. Ebony, before I jump off, do you have any closing words?
I do. Good afternoon, everyone. I just want to say thank you again so much for very thoughtful and engaging presentations to Sarah, Tim, and Christine. I think to your point, Maurice, we don't get an opportunity very often to share our work across these networks. And one of my desires for this annual meeting was that it was curated for us by us, but also giving us an opportunity to share across not only our section, but in other networks, some of the great things that are happening across the country. So I appreciate you all so much for your time, your expertise. Also to Alison and Whitney yesterday for your very valuable presentations. I do hope that you guys enjoy the networking opportunity, and we certainly look forward to engaging you at the annual meeting in Denver, whether you come in person or virtually. Always remember that CHPPD is your home. If you have any questions, please be sure to reach out to our membership co-chairs, Ms. Caitlin Esposito and Madeline Kuhn. They are very knowledgeable and will direct you to an area of your interest. So again, thank you so much. We love you and appreciate you, and continue to stay safe.
I will say a couple more words. For those who are interested, again, today, this was a free event, but we are welcoming donations. They are for our enrichment fund. And so there's a hashtag up there. Oh, not a hashtag, sorry. A QR code that you can select that will bring you to our donation page. And again, our goal is to reach 21,000 this year. And again, those funds will help provide scholarships to attendees to attend the annual meeting, and we also use those funds for the Policy Institute, and so really helping our students and young members get engaged and really engage our section and get enthralled in public health like we all here are today. So thank you all. And again,